This is the second part of implant exposure we were talking about, just as a basic knowledge of what implants are. This is a model we have that shows majority of the tooth conditions, and I would suggest each person to have it. And you're able to show this to the patient and tell them why would you need to even extract a tooth if the fracture line is going through the tooth and it is an unserviceable area, then you end up needing to extract the tooth and to repair it. Here, it's a good model. It shows to the patient how we are replacing the root. In the earlier episode, I did talk about refraining from the use of word screw. Please do not call an implant a screw. It is an implant. So here what we have is a root replacement, and I would show this just like this to the patient and say, just like your natural roots, we are going to go ahead and give you the replacement of the roots. On that root, after some time, we're able to build a tooth. Now, for people who have been doing the implant for a long time, you understand what the implications are, but for a patient or a novice who is starting out the implantology field, three-dimensional ability is very important to have. So having this would give you an idea of how the implant is placed and what the components are. In this video, we are only going to emphasize on the implant components, not actually the placement of implant, which we'll handle at a later time. Here we have a little patient explanation set. It's also wonderful for people who are learning implants, and it shows the components on a larger scale. So I'll pick up an analog of an implant. Of course, the implants are not as big. As I showed the example, a true implant would be almost the same size as the root. So here, comparison-wise, this is a huge model of an implant. And this is what I would show to the patient and say, this is an implant, a model, very large model. And I would tell them that it has screws built into it, these threads, to ensure that we can place the implant nicely into the bone and is accurately placed. Then I would show them these cuts at the tip of the implant, and these cuts show us that once the bone heals up around it, the implant is unable to de-rotate. So once it's in place, the bone heals up and it physically locks in into that slot, and the implant cannot de-rotate no matter how much force is applied. And I've had experience of removing implants that have failed, and what I've noticed is even if this much bone is left, about last 2 millimeters holding the implant is still viable. A lot of times I would suggest, like I have done in my history, I would go ahead and open up the socket, do the debridement thoroughly, chemically also treat the implant, do bone grafting, and I would get regrowth all the way to the top, maintainable bone growth. But anyhow, these are the implant components, and I would tell them it comes with an abutment. Abutment is kind of like the prep tooth. So you have the implant, the abutment fits into it. And here we are using an example in which it's a hex abutment. That means this positive hexagonal shape fits into a negative hexagonal shape inside the implant. You put in and it snaps. Good thing about hexagonal shapes is that you can place it into multiple different facets, but you have definitive position of where the implant crown goes or implant abutment goes. Then you're holding the abutment to the implant through a screw. This screw itself screws into the implant and is made to fit into the implant, which we call the fixture. And on top, the screw head has a driver head which fits into another hex, a smaller hex. Okay, so these are the internal components, but this screw with this ledge holds the abutment to the implant, and then you tighten it up on top like this. And once you tighten it, it is fully anchored. A lot of implant systems would give you an implant along with the abutment already put on it with the screw. It's called a two-piece implant. Sometimes implant and the abutment are one piece. That means you cannot remove the abutment. It's all one solid piece. I don't like to use them that much because in case the abutment fails, I cannot replace it. And I would like to send this abutment to the lab to have the crown made on top of it, and we'll explain that in a later video. But anyhow, as this comes in, we go ahead and place it into the bony socket nicely. Consider my hand the bony socket. Once it goes in to the level you need it to go in, then you go inside and you undo the abutment. You release the screw, and when you're releasing it, you should hear double clicking. Click, click. This click means the screw is totally undone, and at that time you can pick off the abutment. As you pick off the abutment, then this implant head is open inside the bone. You cannot just cover the tissue up on top, because if you did, soft tissue and hard tissue would grow into it and you could not clean it. So we are supposed to cover it with a cover screw. So the name is pretty funny. It fits the description, and you use the same small hex driver to cover the screw or the implant with a cover screw. You cover the tissue up and you let it heal. After 3, 4, or 6 months, whatever the time required is for that area of bone, you open up the soft tissue and you undo the cover screw. You can put your abutment. This is what I like to do. I put the abutment, tighten it, take an impression of the abutment, undo the abutment, take it off, and put a healing screw as the healing is happening. This is all inside the tissue. Now the soft tissue is around the healing abutment, and the healing abutment is in there, and we tighten it and we leave it in there for about a week or so as the laboratory makes a crown for the abutment. Now consider this, that this is how it is, and the patient goes away and we have an abutment in our hand, real patient's abutment that came off, and it is directional. See, these are facets. I like to keep this on the facial to allow for better porcelain attachment, but it has other features too. Sometimes there's a groove running down here, and I would take this and I would take a lab analog. A lab analog is like an implant, but it's not an implant. The inside and the hex are just like an implant, and you send it to the lab. So what I would do is I would take the abutment that just came off the impression of the patient, and I would put it on a lab analog, tighten it nicely, and then I would look at the impression, wherever the impression for the abutment is that came out of the patient's mouth, and I would put the abutment inside there. And then we go ahead and pour this in stone, so the lab analog, which is like the negative or a duplicate of the implant, gets stuck inside the cast. When you take off the impression, you have the exact abutment that was in the patient's mouth on a cast now. On this, in case you wanted to modify the margins like on the facial, I would then modify the margins with a diamond burr to give it better contours, and I would send that to the laboratory so they can go ahead and make a crown on it. Once the crown is made, it comes back. You got to make sure everything is nice and clean, and then you go ahead and take the abutment off, put it on the real implant, and cement the crown. And we'll talk about cementation at a later date. But this is all there is to implant components, and I'll redefine it. You have the hex driver that is good for the screw. Here's a screw that holds the abutment to the implant. There is the abutment. We put that back in, and here's the implant. And of course we have the cover screw that stays interimly after the surgery but before the healing abutment is placed. And this is the healing abutment that goes in for a week or two as a crown is being made for the abutment in the laboratory. That is all there is to it.